Hi, and welcome to my presentation on opioid pharmacology. This presentation is broken up into two basic sections, one of them being a little bit of the background on where opioids originally come from, so which ones are natural. I'll talk a little bit about which ones are synthetic or produced in a lab. So I'm going to talk about also the endogenous opioids, so what's already in your body. And for the most part, the first section is about all the background stuff, including what I just mentioned, and basically anything we could generalize about the medications or opioids in general in the class. So things like side effects and putting a mechanism behind those. So very common things among the class, the drugs in the class, and then moving on to any kind of unique things about the medications, where I have two tables. It's really one continuous table, but it's on two different slides. Talking about the differences in the major important differences in pharmacokinetics and things like that. And then I do get into individual medications that I think stand out a little bit, such as the unique dosage forms for fentanyl, a little bit about tramadol being having more unique receptor activity, and then getting into buprenorphine, which is typically combined with naloxone for the drug Suboxone, and talking about the nitty-gritty kind of what is the purpose of having naloxone in there, and in what situations will the naloxone do what it is intended to do, and what situations will the naloxone kind of just sit there as a bystander, not really do anything, and it depends on the administration method. So we'll get into that later on at the end of the presentation, but starting off with the basics here. So the learning objectives. Okay, so I'll try to go through these pretty briefly because I'll elaborate, a lot more during the slides, of course. Describe the role of basically the different fibers for pain. Okay, the different pain fibers. Identify the origin of natural opioids. Identify synthetic versus natural. So which drugs are synthetic or semi-synthetic? Which ones are natural? Just a little bit on structure-activity relationship, so the chemistry. So what makes an endogenous or synthetic opioid, what makes them kind of an agonist or activator of an opioid receptor, and what makes them an inhibitor, and just a really basic overview of that. Describe the physiologic response to activation of different classes of opioid receptors. Okay, because we have the mu, kappa, and delta opioid receptors. Okay, so in general, mu is doing most of the work. So that's what we'll focus on. Describe the molecular mechanism of action of opioids in spinal and supraspinal regions. What I really mean is what's happening at the level of the neuron, the neurons that we're affecting, because that's primarily what we're affecting. How do we influence the channels there, receptors, release of neurotransmitters? So how does that all working there? We'll talk about that. Describe the pharmacological effect of opioids on unintended targets, such as, for example, SSRI effects, SNRI effects, so affecting serotonin and norepinephrine, for example. Explain the different types of tolerance and differentiate tolerance from physical dependence and addiction. All three of those are different things, but I'm going to go into a little bit more detail on what tolerance is and how that, molecularly, how that works. Describe the role of metabolic enzyme activity and efficacy and toxicity. This is absolutely critical to know that some opioids require enzymatic activity to be activated. Some of them require enzymatic activity to be removed or eliminated. And depending on the opioid, then the metabolic activity will have different effects. Explain what partial agonists are and what this means specifically for buprenorphine, because that's one of the unique drugs in this whole list that is not a full agonist. And if you don't remember what that means, don't worry, we're going to get into that in a kind of a simple manner. Explain what why naloxone is given with buprenorphine sometimes and how different administration routes alter the response. Describe the unique dosage forms of fentanyl with particular attention to their absorption kinetics. So that primarily be the transdermal fentanyl, so the patch, and then Actique, or it could be also used as generic, just the basically it's a lozenge on a stick, almost like a lollipop, but not quite. Maybe not used as often as it used to be, but we'll get into that. So section 1 is introduction to opioids, the physiology of pain, and then the general concept. So pain is not completely understood even today and could be undertreated. One of the big problems with pain is it's really hard to measure chemically or using a lab value. In fact, there's no kind of universal way to do that. So it's still subjective. So you just are going by what a patient says, and that's why we have pain scales. So it's always subjective. We have pain receptors called nociceptors, or so nociception is the sensation of pain, and that would be in peripheral tissues. The type of pain determines the type of drug that we would like to use. So nerve pain might have one type of medication, whereas inflammation would have a different type. Okay, I'm not getting into all the different types of medications outside of opioids here. We're going to focus on opioids for this presentation. This slide is just a basic overview of how pain is sensed and the fact there are different types of nerve fibers doing that. So again, we have the nociceptors, okay, which would actually be specific proteins that are doing that, which we won't get into now, but nociceptors in, for example, the fingers or really anywhere that are transmitting the sensation of pain, okay, and even mechanoreceptors, which are transmitting the sensation just of touch, okay, but that's not the major focus here today. But basically those travel into the spinal cord, okay, and that would be the dorsal region, the dorsal root ganglion. So your dorsal, which is on the very rear or posterior of the spinal cord, is where you're sensing stimuli such as pain, things like that. So what'll happen is, and this is where the really meat and potatoes, or the whatever you want to call it, the major effects of the opioids they're basically working in here to reduce that neurotransmission, particularly to dull the sensation by blocking that neurotransmission into the next neurons, which would basically travel to the brain, and that's where you'd actually sense it. Okay, so if we could terminate the transmission anywhere throughout this pathway, you won't sense the pain, even if you're still getting something that is harmful. You could still kind of block that at the level of the central nervous system. So that's what opioids do. They don't work really peripherally as much as they do centrally, which is spinal cord and brain. Okay, so as you can imagine, that means they must have other effects on the brain, which they do, and we'll talk about those side effects. So this slide kind of shows in more detail the different types of nerve fibers. They basically all synapse at the dorsal root in the spinal cord. You can see that up here. Okay, so we have C fibers, which are slower for conducting the pain stimulus. A delta fibers, and then A beta fibers. The A delta fibers are myelinated. Both of those, A delta and A beta fibers, are myelinated. Remember, myelination means it's a faster conduction because you get a much more rapid electrical or basically current flow through those. Okay, so this means that there are pain pathways that are slow. That would mean you'd have an instant sensation of pain, and then ones that are delayed. Okay, so an easier way to look at this, I think, is that actual graph here. So the idea is that the A delta fiber would give you your initial immediate pain, and then a chronic pain still associated with the same region of the body, the damage to the same region of the body, or an insult, kind of a trauma or something. But they're both these are both coming from that, but one of them is going to be later, and that would be the C fiber. Opioids can help both, the opioids, but we do have medications and things, and not so many of them at this point, but maybe in the future we'll have more that are associated with delayed pain and things like that, such as blockers of substance P, which is more important for delayed pain. Okay, but that's not really something we're going to focus on. Of course, it's going to be more just opioids here. So a little bit more detail, the pain fibers generally use glutamate to activate receptors called AMPA. and I'll get into an animation on that I made. So that's the rapid pathway, but even the delayed pathway uses glutamate. So just to give you an overview of glutamate, that is, of course, that's an amino acid, but glutamate is also a neurotransmitter that is typically considered excitatory. So excess glutamate in the brain does a lot of stimulation, a lot of excitatory things, also in the spinal cord. So the major communication mechanism for activating for one neuron activating another neuron in a lot of areas in the spinal cord and brain would be glutamate. So if we can block glutamate transmission, we block the sensation of pain. Okay, so that's one of our goals here on a molecular level. So just to give an overview of the other classes of painkillers or analgesics, we'd have non-opioid and non-steroidal. So that would be, for example, NSAIDs, such as ibuprofen, indomethacin, and naproxen, etc. And then Tylenol or acetaminophen, which is the only, out of all those, is it does not treat inflammation, right? That's the one that does not, whereas the NSAIDs do. In most cases, for a lot of different types of pain, these are adequate, okay, but sometimes they're not. Steroidal are excellent for inflammation. Unfortunately, they come with a lot of side effects. That would be things, steroidal would be things like prednisone, dexamethasone, methylprednisolone. There's so many of them. Okay, but those have very, very many long-term side effects and short-term side effects that we try our best to avoid steroids any longer than necessary. Now, opioids are the best option for severe pain. To this day, they're still the best option. Now, there are some studies on non-addictive ways of blocking perception of pain as strong as opioids, but nothing has come to the market yet. So hopefully we'll get there. Having medications that don't cause any addiction, that would be ideal there. So what are opioids actually? So what does that mean, and what are opiates? Okay, so I'm okay if nobody memorizes the difference, but there is a difference technically. Opiates are compounds that can be directly derived from the opium poppy plant. Also, opiates are natural. Opioids are a broader class and include the natural opiates as well as synthetic drugs that resemble opiates. So if you just use the term opioid, it means pretty much anything in that, there's binding to those receptors that we're going to talk about. So anything in the class, whereas opiates are technically natural compounds. Again, that's more of a just an academic discussion that we don't really need to worry about memorizing. So where do opioids come from? So originally, and still to this day, right, they're coming from the opium poppy. That's where we get natural opioids. It's also where we get a lot of our starting compounds for semi-synthetic opioid production. Opiates are considered alkaloids. That just means they have nitrogen in them, in the chemical structure. So alkaloids is a term that's used quite a bit. We don't necessarily usually define it, but just make that very clear there. It just means they're containing nitrogen, which are basic functional groups. There's about 20 or more alkaloids in the milk of the poppy, which is what you're seeing here. Okay, so this is a very thick resin that actually is also considered like a latex because it has some elasticity. And I've personally never seen it. That's probably a good thing. I've never had it in person to play with it or to see how elastic it is, because obviously it's not something you're legally allowed to possess. But it is, it's more than just codeine and morphine, and it has a lot of other substances in it that are kind of in that network or in that latex there. So morphine and codeine are the two major natural opioids. They are both medications as well. So we're still using those as even though they've been around for, I'm sure, longer than humans have been around. There's no reason why in some cases, we can't just use one of these and get a good effect. These are just two examples of countries where you'll see opium grown, Turkey and India. Obviously, special climate requirements and things like that can't be grown everywhere. But to this day, they're often still using the extracts to starting point for producing synthetic ones. But what are the main features of the opioids that are pertinent to pharmacists? I just want to give you a little bit of a warning. This next slide is something that I just wanted to throw in here. The subsequent slides are not all of them are directly connected to it, but the point of the next slide, is to give everybody an overview of what are the main things on the top of our heads, or basically what do we have to be considering overall when you're thinking about opioids in patients. And then I'm going to get into more of the actual science behind them, though. So what are the pertinent features that pharmacists and other healthcare professionals would think about? What receptor does the opioid bind to, and is it an agonist or antagonist? That is absolutely critical. Agonists are alleviating pain. Antagonists are blocking those agonists. So we'll get into those specific ones in a little bit. Does the structure allow crossing of the blood-brain barrier? That means how well does the opioid cross into the brain, and how rapidly, and that determines basically how rapidly it will have analgesia or pain killing, and not just the brain, the spinal cord as well. How rapid is the onset of analgesic action and termination of action? So when we give an opioid by different routes, we need to understand when pain relief should be expected. We need to understand how long that will last. And that depends on how it's eliminated and how it's absorbed. How does opioid tolerance work? Is it synthetic or natural? And how does this influence an allergy? I'm not personally getting into the allergy side of it. That'll be more on the clinical side. But just understand that in general, natural opioids and synthetic opioids often don't have cross-reactivity, so sometimes you can use a synthetic if you're allergic to a natural. So that's just where I'm going to leave it at this point to simplify it. Does it have off-target receptor activity, and is this useful? Such as SSRI activity, so serotonin upregulation, or preventing serotonin reuptake, and then norepinephrine reuptake inhibition, and things like that. For the most part, I would say that's not typically considered a desirable pharmacological effect, but in some cases it may be, I suppose. What are the main side effects, and do they differ from opioid to opioid? Is the opioid combined with other analgesics? So I'm not going to get into that much here in this presentation, but what a pharmacist would have to consider is, how many different combination. Basically, if a patient's taking an opioid with acetaminophen or some other substance, or which is Tylenol, is that patient on other medications that would possess the same substances? So 2 medications with Tylenol, for example, we have to watch out for overdose and things like that. So that's just a practical consideration. So opioids are classified by different ways. So intrinsic activity at the receptor. Agonists are all the opioid analgesics, so all the drugs that are used therapeutically for pain in the opioid class are agonists. Antagonists are specifically to treat opioid overdose or some other indications that I'm not going to get into, but primarily for opioid overdose, or to deter abuse of an opioid in special combination products. The main receptor targets are mu, kappa, and delta. Unfortunately, there's not a lot of information on what kappa's role is, those kappa receptors in the body. It's almost in every case, or I should say almost everyone in this field will consider the mu receptors the most important receptors. So that's what we're looking for, mu targeting. Okay. Some of the kappa activity can cause dysphoria or feeling unwell. So that's one of the pieces of information we do have about that. So if a drug has more kappa agonist activity, it might cause a feeling of discomfort or being generally unwell. Delta receptors appear to play a secondary role that appear to enhance mu activity. So it doesn't seem to work as well on its own if you only had a delta agonist. So then we're just kind of augmenting the mu function here. So just some examples, and I think this is almost probably all inclusive, but examples of agonists. Natural ones would be, first of all, endogenous, meaning it's already in your body, would be enkephalins, endorphins, and dynorphins. Plant-based natural agonist would be, well, opium is not a chemical, it is a mixture of things. So that's the liquid latex that contains morphine and codeine. So the morphine and codeine are the actual pharmacological components. Semi-synthetic, oxycodone, hydrocodone, hydromorphone, oxymorphone, and heroin. Heroin is the one there that's obviously not used for any therapeutic purpose. So that's a C1 scheduled substance. The other ones are C2, which are still controlled substances but used prescription based. Semi-synthetic means chemically we're starting with the natural ones and then we're making these out of them. So the starting products or reagents would be morphine and codeine. Synthetic would be methadone, fentanyl, tramadol, and buprenorphine, for example. And there might be a few other ones that we'll get into. Those are some of the main ones. Antagonists are synthetic, and that would be naloxone and naltrexone. Naltrexone is not commonly used for opioid overdose because naloxone is so effective, and it's got a long history of, again, use by different routes to do a very good job at reversing the major detrimental side effects of opioids. So getting started on the endogenous opioids, we have enkephalins. Those are located in vesicles with catecholamines in the sympathetic nervous system terminals in the adrenal gland throughout the central nervous system. There are two forms, met and lu enkephalin. They differ by one amino acid. Okay, they are selectively activating the delta receptor. Okay, and enkephalins are basically neurotransmitters that act like morphine to modulate the other neurotransmitter release. Okay, so they have a very short half-life. Okay, compared to a lot of the prescription opioids, and a little bit more complicated. So there's met enkephalin, pretty complicated structure compared to morphine, for example. Endorphins are also endogenous. This is a really interesting concept. The substance beta endorphin is cleaved from pro-opiomelanocortin, or POMC. POMC is a large peptide that is kind of a reservoir for these endorphins. So your body doesn't make it doesn't have to make endorphins immediately when you have a sensation of pain that you want to relieve. What happens is it's going to have a reservoir of POMC that will release this beta endorphin when you need to very rapidly cause dulling of pain. If you've ever had a traumatic physical traumatic event where you've gotten a lot of damage to a region, you might notice you may not feel it as much as you would expect, and that's because of release of endogenous opioids, again, like endorphins. Beta endorphin is packaged into vesicles in the brain and is released when needed. So it's kind of held back in a reservoir. And beta endorphin selectively activates the mu receptor. So that's, again, one of the most important receptors in analgesia. Okay, and just FYI down here, you'll see that there are other important peptides released from POMC. That would be including adrenocorticotropic hormone that's for triggering cortisol production, a melanocyte stimulating hormone. So this POMC has a lot of other roles in the body other than just possessing endorphins. Dynorphins are derived from prodynorphin, which is just another related substance. They selectively activate the kappa receptor. Okay, all endogenous opioid peptides contain this tyrosine, glycine, phenylalanine. Okay, and then there's one more amino acid that's either methionine or leucine. So this sequence here is common amongst all endogenous opioids, except one might have the methionine and one might have the leucine. Okay, so this is met enkephalin, so it has methionine in it. Okay, if it had leucine, that would be lu enkephalin. So we have different types, but really it's just a small peptide. Whereas endogenous opioids are already in the body, xenobiotic opioids by definition means foreign to the body. Xeno, of course, being foreign. So we have, of course, the ones that I talked about, natural xenobiotics that we've morphine and codeine, semi-synthetic, oxycodone, hydrocodone, and heroin, which is just there for comparison purposes. Synthetic will be tramadol, and this is just showing you that there are enantiomers here, and actually it's administered as the racemic mixture, so 50% of one isomer, 50% of the other isomer. Buprenorphine, methadone, and fentanyl, so those are all synthetic. The antagonists for comparison I have here are naloxone and naltrexone, and the idea is, in terms of the structural activity relationship, if you add quite a bulky group, and here I have chunky group, same idea, a bulky group down on this amine, it becomes an antagonist. And as you, and I'm going to talk about this later on, but if you look at buprenorphine, you might think, well, that's pretty bulky there, so why isn't that an antagonist? The truth is, that's a partial agonist, so it's kind of in between an agonist and an antagonist. So this brings us to the function of activated opioid receptors. This slide is actually just a really broad overview of some of the functions of opioid receptors. The next slide will be more detailed, and then it'll get even more detailed with each kind of effect one at a time and exactly what that means. So let's just start with the overview here. First is the brainstem. Opioid receptors, when they're activated in the brainstem, they will suppress respiratory drive, reduce the urge to cough, so that's why codeine has been used for a long time as a cough suppressant. However, the suppression of the respiratory drive is never something we desire, and that means it's going to lower your respiration rate. Triggering nausea, also in the brainstem, and we'll talk about exactly how that happens in a little bit. So yeah, opioids in general can cause someone to feel a little bit nauseous and have a high risk of vomiting. Constriction of pupils, which is also called meiosis, okay, and then some potential for bradycardia, not profound bradycardia, which is, again, this is slowing down your heart rate. Nothing profound, but there's a tendency to lower heart rate. In the medial thalamus, there's some ability to decrease pain there that could actually be intensified by emotional situations, but I'm saying the opioid agonist can suppress that. In the spinal cord, that's really one of the main sites of action. The spinal cord receives, as I mentioned already, receives and integrates sensory information for pain. The opioids will attenuate that painful stimulus, that sensory pathway, or actually prevent communication between the sensory pathway and well, the initial sensory pathway, and then before it travels up to the brainstem, it can be terminated. The hypothalamus, unfortunately, opioids have some effect on endocrine function. I wouldn't say profound, but definitely there are some side effects related to that. The GI tract, obviously, anyone who's taken an opioid might be very familiar with this, either illicit opioids or prescription opioids, and that is the suppression of gastrointestinal function and constipation. So breaking it down into the different effects here by receptor, the reality is most of these are mu opioid receptor mediated. And this is not something I personally think anyone should try to commit to memory in terms of which receptor is where, except maybe the idea that the kappa receptor activation does cause a feeling kind of opposite of the mu receptor in terms of your emotional state, and that would be dysphoria. So feeling maybe it's very nondescript, but maybe a feeling of sadness, uncomfortable feelings, just not calm or serene. Whereas the opposite with mu activation would be euphoria, and then sedation as well. But feeling good, that's why people use heroin and things like that. Physical dependence, respiratory depression. So physical dependence, we're going to talk about the difference between that and addiction and tolerance. suppress cough reflex. I don't have that there, but it's the mu-opioid receptor. Paritis is a strange effect that is from histamine release. Meiosis, or constriction of pupils. Bradycardia, emesis, which is vomiting, slow GI motility, and then, like I said, all these the endocrine effects. So all these hormones can be affected here. A tolerance develops to most of these, except meiosis, constipation, and pruritus. And the truth is, the most bothersome long-term effect would be constipation. The majority of the other effects will decrease over time, and that's the tolerance. And even analgesia will decrease over time, meaning if repeated exposure to the same dose, or even to the point where if you're escalating the dose, it may, you'll gradually basically get some kind of a tolerance where you still need to escalate it even more to get pain relief, and even the effects on the respiratory system, the effects on everything except really constipation and maybe a little bit of the meiosis and the itching. Okay, so, and that's just a reminder that the delta receptors don't appear to do much alone, but they do appear to enhance mu-opioid activity when the mu-opioid receptors are activated. So now I'm going to break it down into each effect, for the most part in the same sequence that we just talked about. So analgesia is the pain relief. Spinal and supraspinal, meaning in the actual brain, there is supraspinal. Those analgesia effects are caused by activation of mu and kappa, again, mostly mu. This means opioids work on neurons in the spinal cord and in the brain. Okay, and then the next few slides will illustrate exactly how opioids reduce glutamate-based activation of neurons and glutamate release from neurons in the spinal cord. Meaning opioids can prevent glutamate release from the sensory neurons, and then actually reduce the response of the postsynaptic neuron. So the whole idea there is, without glutamate release or transmission, the sensory signal is not sent to the brain, and we don't know that there's some kind of harmful stimulus. We don't feel it, so you're dulling that. So this is a diagram, of course, of the spinal cord, specifically a cross section. We have the dorsal horn and the ventral horn, and this is just kind of the introduction to what's going on with the neurons. So basically what happens is we have primary afferent, which means sensory neurons receiving a signal. Okay, what I'm doing is I'm not going to talk about this other pathway here, but this is one of the pathways that would trigger, for example, if you had inflammation and muscle activation, like a muscle spasm, this could be a recycling loop that goes over and over again. So that's a little bit separate because that is actually a motor pathway, whereas this is a sensory pathway. So the first one would be starting off sensory and then converted into a muscle activation, whereas this pathway up top is taking the sensory signal right into the dorsal horn of the spinal cord, sending glutamate to another receptor, yeah, but also another neuron, and then traveling up into the brain through the spinothalamic tract. And if we could terminate the signal here, we do not experience the pain in our, right? We don't even sense it, right? Because it's terminated before it reaches the brain where it can be processed. So that's the idea. And what I typically do is have red as the bad guys, blue as the good guys. But what I mean, what it means in this case is that red is really glutamate, blue is the opioid receptor here, and then the agonist. So the circles here are the actual agonists or activators, whereas the other shapes are the receptors there. So this now is getting into more detail. Now if you go back and look at the previous slide, imagine now this is that first neuron, that first sensory neuron before it goes up to the spinothalamic tract neuron. So what we're trying to avoid is the effect of this AMPA receptor and the NMDA receptor. These two guys actually work together, and they do respond to glutamate. Okay, so the way this is going to work is that glutamate is a pretty pretty commonly used neurotransmitter, from neuron to neuron to neuron. So glutamate would activate some of its receptors. That would ultimately, long story short, would end up releasing more glutamate from this neuron, and then that would then activate the next neuron. What we're trying to do is prevent this vesicle containing glutamate from being released, or we don't want to prevent it from fusing with the membrane of this neuron, so the glutamate can't get out. No, in the common language in basically cells in general is to avoid activation. We typically remove cations or promote the entry of anions or negative. In this case, they're just atoms, not really molecules. But the whole idea is if the neuron is hyperpolarized, that means it's more negative with respect to the outside extracellular space. That negative potential prevents activation. It prevents neurotransmitter release, and that's what we want in this case. However, if we make it more positive, we activate neurotransmitter release. So we want to avoid that positive activity. So that means if we're not going to block these receptors here in red directly, then maybe we can block some downstream effect that they have. Okay, so imagine now we have a painful stimulus. AMPA is activated, cations come in. The cations end up changing the conformation of the NMDA receptor. That's going to show a pocket forming here just to represent that then has an affinity for glutamate as well. That glutamate will bind, or open up that channel, bring in more cations, and calcium and sodium. And at this point, we're getting closer and closer to the voltage that we need to release this vesicle. However, the one other player in this is this final voltage-dependent calcium channel that it waits for the voltage to rise and rise and rise until it gets to a certain point where this then is going to open up. So it's voltage gated or voltage dependent. If that calcium does come in, and there's enough in here, that triggers through an involved mechanism with other proteins that we're not going to get into, but it's going to trigger vesicle fusion with the membrane and release of glutamate. Okay, and when that glutamate is released, it activates basically the next neuron, right, that also has glutamate receptors, and that will travel to the brain, that signal, and then you'll feel the pain. So basically, we're going to try to prevent all this from happening by activating an opioid receptor and shutting down some of this activity that we're just going to talk about exactly how it happens in the next slide. So now, again, in the situation where we have an opioid receptor agonist, like any of the drugs that I talked about, or even heroin, actually, we activate the opioid receptor, and then that's going to activate something I haven't really talked about much, is the potassium channels. And remember, potassium is always concentrated inside the cells of the body. So as soon as you open that channel, it wants to rush out, and that makes the cell more negative. Okay, so that hyperpolarizes the neuron and prevents this voltage-dependent calcium channel from opening. Okay, no calcium influx means no vesicle release, means no glutamate release, or any other neurotransmitter that happens to be in there. So it could be a substance P, which is also related to signaling pain. And the same thing happens in the next neuron. So ultimately, we're just terminating communication from neuron to neuron. So if we activate that, again, activating the potassium channel, potassium leaves, the cell gets hyperpolarized, we can't bring calcium in, and then the vesicle is going to get stuck in there. It will not be released. And there you have why opioids block pain perception, but they don't block the very beginning of where the pain is initiated, where you might have a cut, you might have a muscle damage. It's not really affecting that at all, that inflammation or anything. It's just blocking your brain from sensing the pain. Okay, so I made this little cartoon to kind of show anthropomorphizing the opioid receptor, saying if it had a goal when it's activated, its goal is to block that glutamate-containing vesicle from being released. So now we're continuing on the different effects of opioids. We've pretty much finished the analgesic effect, which is their main therapeutic purpose. Now we're going to talk about euphoria and dysphoria. Not too much more than we already said, that I already talked about, so it'll be pretty quick. So euphoria is obviously the primary reason for opioid abuse. And opioids do appear to release dopamine in the nucleus accumbens, which is the reward center in the brain. And I'm not going to get into that any further because we're not going to be talking about all the complicated brain physiology, but just understand that the mu opioid receptor and the delta could augment that, but the mu is the main one that's initiating euphoria. Dysphoria is, again, feeling unpleasant. It's a very nondescript word. I know unpleasant, what does that mean? It just means emotionally feeling unwell, maybe fear, maybe sadness. So dysphoria is what it's called. Next is sedation and hypnosis. Opioids, if you look at, for example, the Poison Center's database, they don't really list opioids as hypnotics. Hypnotics are a separate drug and toxin class. That would be things like benzodiazepines or benzos, etc., and barbiturates. Opioids can cause sedation, absolutely, but they're considered a different drug class. Okay, so they cause drowsiness or sedation. They can cause difficulty concentrating, obviously, so pretty common issue there. The most common reason for death from opioid abuse or overdose is respiratory depression. The thing that ends up being fatal is just not getting enough oxygen because your respiratory drive goes down, so you can't even breathe faster if you want to because you're basically obtunded, so your consciousness is much lower if you get to that point, and then you can't really voluntarily fix this decrease in respiratory drive, and that's primarily mu receptor mediated in the brainstem, specifically medulla. And opioids decrease or depress all phases of respiration. That would be rate, volume, or minute volume, and tidal exchange. Right, so it's the depth and the rate of breathing, basically. And this could be compounded, of course, by other drugs such as anesthetics, tranquilizers, sedative hypnotics like benzodiazepines, like I said, and then drugs very related to those, maybe some of the sleep aids like Ambien or Zolpidem, or like I said, phenobarbital, or any one of those barbiturates. Again, reiterating, this is the primary cause of death from opioid toxicity. So when we treat opioid overdose, our main goal is to get our respiration rate back up in the normal range to prevent damage, right, to your brain and other organs. Cough suppression is due to suppression of the cough centers in the medulla. Codeine has been used historically and can still be used for that, but any opioid should have some ability to suppress cough. So we're going pretty fast because I kind of already summarized all this stuff. So pupillary constriction or meiosis is basically, if you look over here on the left, heroin intoxication or any opioid should cause this constriction or pinpoint pupils. Whereas if you gave, for example, if you gave someone the antagonist naloxone, or if they were just being undergoing withdrawal from an opioid, it might go actually opposite. Of course, it would dilate, but it might actually even get bigger than normal in some cases and be, it's called mydriasis, where it's very large. So one of the hallmark signs of opioid use is pinpoint pupils. And the opposite, and this is FYI, but the opposite is true for stimulants such as amphetamines. They cause a very dilated pupil like this. So that's one way toxicologists distinguish between different overdoses. It's just one sign out of a constellation of signs and symptoms. A nice one to look at, again, is just pupil diameter because it's really easy to determine. So opioids stimulate the cholinergic oculomotor nerve to trigger meiosis. You don't really need to memorize that detail, but that's just for your information there. Next is pruritus, which is itching and histamine release. So pruritus is typically more common with IV injections, and that's due to an actual non-allergic type of release of histamine from mast cells. So what I mean by that is if somebody says they got IV morphine and they got itchiness, so they tell you they're allergic to morphine, chances are that's not true. Chances are they don't have a true allergy or true anaphylaxis. So it's not a full full where your bronchioles and your lungs constrict and the full spectrum of an allergy. It's not like that. It's just histamine release from mast cells that mostly causes a lot of itching. Primarily is that pruritus. And that could be accompanied by injection site redness or erythema and hives. Again, that's not a true allergy. But true allergies do exist for opioids. That's just going to be different from what this is. Next is the cardiovascular effects or central sympathetic tone. And that means the sympathetic nervous system activity coming from the brainstem and reaching out to the rest of the body. So it's got a broad or sweeping effect on the sympathetic nervous system, but it's not a profound effect. They can cause a moderate decrease in sympathetic nervous system activity through the mu receptor. That would be a moderate decrease in norepinephrine release. So a little reduction in heart rate, a little reduction in the force of the heart contraction, some vasodilation. So bradycardia is a slower heart rate, and vasodilation is just dilation of your blood vessels, so you can get a higher risk of orthostatic hypotension. So when you stand up rapidly, you might get dizzy or faint more easily on an opioid because of that vasodilation. But this is not one of the most bothersome side effects, honestly. Next would be nausea and emesis. So nausea is the feeling of that you might want to vomit, and emesis is actually vomiting. It's thought to be due to the mu opioid receptor, and specifically opioids have been shown to irritate something called the chemoreceptor trigger zone, and that is approximately where that arrow is, right in the brainstem, in the medulla. That has receptors that if those cells there are harmed or irritated, they'll release certain neurotransmitters that will activate receptors. Okay, we don't need to get into the specific receptors right now because this is a separate lecture, but please understand that that opioids within the actual central nervous system there can trigger the urge to vomit, as well as in the if any of them are getting in the intestines from an oral dose, or even IV opioids getting into the intestinal cells from the capillaries, you can still get initiation of nausea and vomiting even from the intestinal zone. So there are at least two different sites for sensing toxins, and again, one of the main ones is the CTZ and the medulla there. Some of the neurotransmitters, and this doesn't need to be committed to memory, but some of them involved are serotonin, substance P, and some other ones. So serotonin, you may know, is a really, really popular target for anti-emetic drugs to prevent vomiting. So those would be the serotonin antagonists. Skeletal muscle effects. Skeletal muscle rigidity can occur with large IV doses due to dopamine release, striatal dopamine synthesis, most commonly observed with fentanyl. So not every opioid is going to show this. Okay, so because fentanyl penetrates the blood-brain barrier very rapidly, so as soon as it's injected, very, very soon after, it's going to have central effects in the brain there. Next is gastrointestinal and other smooth muscle effects. In general, opioids decrease digestive and urinary function. In the stomach, gastric emptying is delayed. That means the stomach will retain food longer before it pushes it into the small intestine, so it's going to sit there longer. Intestinal peristalsis is slowed, so your muscle activity in your entire intestinal tract is lower, meaning you're not moving it's called chyme, which is the digested food. You're not moving it as quickly as you normally would, so you'll desiccate your stool. Bile flow is reduced due to constriction of the sphincter of Oddi, which is right here. That is a muscle that is allowing secretions from the gallbladder and the liver, which again, that's all coming into the bile duct. Those secretions and the secretions from the pancreas, which is all your digestive enzymes and things, those come together at the sphincter of Oddi, and that if that is constricted, first of all, the bile will back up, pancreatic fluid will back up, and you won't get as much digestion because, right, you're not getting these substances into the duodenum in the small intestine. But you could also cause pancreatitis due to backing up of this pancreatic fluid, so pancreatic inflammation. So if you had to generalize what opioids do to the GI tract, it's almost a complete suppression of GI activity, overall suppression of enzymatic activity, muscle activity, secretions, etc. And then urinary retention is probably not the most bothersome side effect, but it is another side effect. So I just have there just showing very slow, a drop here and there, very slow urination or urine output. All these effects are related to muscle contractility changes or decreases, okay, whether it's at the level of a gland muscle or the smooth muscle of the entire GI tract. So because the gastrointestinal side effect of constipation is so prominent and it doesn't really go away, and we do have medications that directly oppose that on a receptor level, I wanted to talk a little bit more about the mechanism. So slowed intestinal motility occurs when opioids activate the mu receptors in something called the enteric nervous system. So your GI tract, believe it or not, is not just muscle and digestive enzymes. It is loaded with neurons that are very, very numerous. Okay, so some people consider it the second brain. And this nervous system, in this case, when you activate the mu receptors, you reduce acetylcholine release. You may remember that acetylcholine is, in the digestive system, it is an activating neurotransmitter. It stimulates digestion, muscle activity, and other things. So acetylcholine, by inhibiting that, we inhibit all the things that I talked about in digestion. So don't worry about the rest of the details here because we're going to cover that in the next few slides. But this is what causes the constipation. In severe cases, someone with an overdose, or if they have concomitant physiological issues such as if they have neuron damage or stroke, they even have a higher risk of this, but it's called ileus. And ileus is total lack of bowel activity. And that would be, again, the severe case where you get a really, really dried up stool from all the water being absorbed, and you might have a need for surgical intervention there to get that out. So what I wanted to do is compare gastrointestinal motility in the absence of opioids and then in the presence of opioids, and show you what is supposed to happen and then how we're inhibiting that. So when food is present, and I'm going to represent that just as a burger here, but of course it would be digested by now. But when it's present, a signal normally travels on enteric neurons to trigger contraction. So what will happen is, without getting into too much detail, there are some cells and receptors on the mucosal membrane here that would signal to the enteric nervous system, this is represented here by these neurons. The first one here would be a cholinergic interneuron is what it's called. And again, I bypassed some of the other parts of the pathway, but this cholinergic interneuron releases acetylcholine onto a muscarinic receptor, which then activates another cholinergic neuron, which then releases more acetylcholine to activate the circular muscle, which would cause contraction. And the interesting thing, to me at least, is that the muscle before the food will contract, whereas the muscle that's coming after the food or where the food is going to be going will relax. And that way you're going to move it in the correct direction. Okay, so but what we're gonna talk about here is how you're preventing this contraction with opioids. So again, just go over just brief animation of what's normally happening. Food, nutrients activate the cholinergic interneuron, releases acetylcholine that activates the next cholinergic neuron, and then you have contraction. Then your food will move appropriately towards the anal direction, right? And then hopefully you won't spend too much time, or the food won't spend too much time getting water absorbed, so it won't be too desiccated. However, when we do have opioids on board, we're going to activate the mu-opioid receptor much more than we would with the endogenous enkephalin and other opioid agonists. So when we're gonna basically get the medication agonist, and it could be any one of those that I talked about, and that does activate the receptor. However, activation of the mu receptor kind of slows down or decreases the activity of the terminal cholinergic neuron to reduce acetylcholine release, and that would reduce the circular muscle contraction, and that would basically make the mucosa just kind of inactive in the terms of the muscular ability of contracting that mucosa. That'll be inhibited, so it'll just kind of sit there. The food will sit in, or the nutrients there will sit, and water will get absorbed, and the stool will get very desiccated. And in severe cases, you can get ileus, or which is basically is total lack of bowel activity. So it's possible that the interneuron might still get some activation, but the ultimate outcome and the most important point is that you're blocking that final activity of acetylcholine release. And I'm representing that as kind of the neuron there fading away. Not that it's really disappearing, but it's just not releasing much neurotransmitter at that point. So as you see, I'm showing the mucosa getting kind of gray, just indicating that it's inactive. And again, you're just going to keep absorbing more and more fluid, and you're not going to really be secreting as much as you normally would. So the net effect is it's a really significant reduction in the hydration there in the stool. And of course, the main side effect that is not having a tolerance, or we're not seeing a tolerance to, is constipation. And that's just to help you kind of remember that up the top left there. You can look at it as circular muscle is kind of sleeping, doing nothing really, and the food is camping out and it's dehydrating and it doesn't have any fluid. And that pretty much wraps up the opioid-induced constipation discussion here. So we're almost done with the overview of opioids, and I want to wrap it up here with effects in pregnancy and on the neonate, and then talk about tolerance and physical dependence, and then we're going to move over to getting into just the detailed table of different opioids, just comparison, and then the few dosage forms that are really special, and then that'll wrap up the whole lecture. So first of all opioids can cross the placenta, so all opioids can get into the fetal blood supply. Now please remember that the fetus is not breathing because their lungs are collapsed. They're getting their oxygen from their mother, only from the mother, right? So at that point, we're not worried about respiratory drive, respiratory depression in the fetus. However, we're to some extent concerned about the fetus becoming physically dependent on an opioid. Okay, so when they're born, we don't want to have that physical dependence. However, opioids have no teratogenic effects. That means they don't cause birth defects or abnormalities in development of the baby. Like I said, physical dependence in utero may develop. Neonates may go through withdrawal, which is a lot of sometimes very kind of non-specific effects, such as agitation and things, and then maybe some more obvious effects like on the GI tract and things like that. But I'm not going to, I'm not going to get into too much detail on that. Opioids given during labor can cause respiratory depression after the baby is born. So please keep that in mind. Even though the baby's not breathing in the womb, it needs to breathe. Hopefully, and hopefully that'll happen almost immediately after birth. Or the doctor may have to coax the baby into expanding its lungs by giving it a little pat on the back or something like that, or even a firm pat on the back. But basically, once those lungs are open, they need to start working. And if there's a significant amount of opioid in the baby's system, you may already have respiratory depression. Okay, and this is not to say that opioids are never used in pregnant women. It's to say that you have to have a lot more attention, right? Be much more careful, and particularly with someone who might be using illicit opioids and overdosing, there's a big concern there. I just wanted to add, in a special case here, a lot of these drugs are not prodrugs, but codeine is a prodrug, meaning when you take codeine, it is not really active until it's metabolized, or this is very low activity until it's metabolized and converted into morphine. Okay, and that requires the hepatic enzyme cytochrome P452D6. There are people in general, but particularly here mothers, with extensive metabolizer status. That means they have excess CYP2D6 activity, and they can produce morphine too rapidly and then pass too much through the breast milk and actually cause lethality, or basically it's been shown to happen. And there was a case several years ago where a baby died from having too much morphine because even though it doesn't happen very often, the mother was producing way too much morphine even with a normal dose of codeine. So that's just highlighting sometimes the importance of understanding the pharmacogenomics associated with some of these drugs. Now, so we're moving on to tolerance. Please remember or understand that tolerance is not the same as physical dependence. They're very similar, but tolerance means that the effects of the opioid are wearing down or getting weaker and weaker. Physical dependence means you depend on the drug because if you stop it, you'll have physical symptoms or side effects that are really bothersome or detrimental. Okay, so there's a big difference there. So innate tolerance, though, is an insensitivity to opioids before the first exposure. That means you're already going to have a poor analgesic response, or even the other effects of an opioid. You might have a weak response to begin with because of some certain reason. It could be because, for example, if you're taking codeine, maybe you don't have enough cytochrome P452D6, so maybe you can't activate the codeine. Maybe you eliminate the opioids faster than someone else because of some other reason. But that means it's happening before you've even taken a single opioid. So the first time you have one, you already have a tolerance. Okay, and that's not something that's probably as commonly discussed as acquired tolerance, which is that hallmark reduction in effectiveness over time. So that's with repeated or prolonged use. There's a cross tolerance with other opioids, obviously because they have the same receptor target. So it doesn't matter if you're taking codeine, morphine, methadone, any opioid could potentially cause a downregulation of its receptors, which then makes the other opioids also less effective because it's a common target. Tolerance to respiratory depression and euphoria is rapid. Tolerance is slow to meiosis and Paritis. For some people, that might not go away at all. And then constipation really never goes away in general for people. So constipation is the most dominant long-term effect that there's really no tolerance to. Tolerance to analgesia is patient-dependent. If you look in the literature, some experts say they haven't really observed analgesia tolerance in their patients because it's so hard to distinguish between tolerance of the drug and escalation of the disease. So is the patient actually having more pain, or are they having a weaker effect from the medication? So that's still debated in the literature as to what is the real prominence of that tolerance. But I think it's generally accepted that physical, or not physical, but a tolerance to opioid-induced analgesia can happen. So I already mentioned innate tolerance, and I won't dwell on it, but I want you to understand that in many cases that's related to unfavorable pharmacokinetics. Okay, that's a little different from the acquired tolerance, which is usually because of pharmacodynamics, and I'll talk about that on the next slide. But unfavorable pharmacokinetics means poor absorption or fast elimination, or even poor activation of the drug. And then see the last bullet there's hyperactive P-glycoprotein, and that's the transporter that many opioids are substrates for, and that transporter generally pumps drugs out of the blood and into the GI tract, into the urine, and even out of the brain, from the brain into the blood. So it generally is getting drugs out of the systems out of the body, but also out of the brain. Okay, so if you're taking an oral opioid, hyperactive PGP, because it's embedded in the intestinal wall, that might not even let the opioid be absorbed to begin with. So before it even gets into the blood, it might get pumped or pushed out of the intestinal cells while it's trying to get in there, and then eventually get eliminated fecally before it even gets absorbed in some cases. So higher PGP activity means lower activity of the opioid, so lower efficacy. If you have to have a PGP inhibitor, the opposite holds true. Then you have excess opioid absorption and excess blood levels, because you also won't be eliminating it very well because PGP is all over the place. Like I said, acquired tolerance is often a change in the pharmacological effect right at the receptor. So that's called pharmacodynamics and receptor desensitization. So I'm going to skip the text here because we have it on basically I have it on the animations coming up. So this is going to be, again, an example of acquired tolerance. And I have an opioid drug up top left there. I'm going to show it. First of all, when you're just starting it, patient's just starting it, it's doing what it's supposed to do. Without getting into a terrible amount of detail, the opioid receptor, it's a G protein coupled receptor, so it does activate a G protein, which will activate its normal effectors, which ultimately, I'm going to show this turning blue here. The blue is symbolizing that you're getting pain relief. So the G protein is going to, it did its job, which is, just for simplicity's sake, I'll say it suppressed the neuron. Remember, by blocking, opening the potassium channels and preventing calcium influx and the things that I've talked about before. But normally the G protein would go back to the receptor and it could be activated again. But if we stimulate the receptor too much, with too much opioid or too long, we do something called, desensitization, and that is related to recruitment of something called G protein receptor kinase. And that kinase, because it is a kinase, it does phosphorylate the opioid receptor, and that basically disconnects the G protein and renders it inactive. That also recruits something called beta-arrestin, and hopefully you could remember this easily from the name, but it is essentially arresting the normal activity of the receptor. And beta-arrestin does that by recruiting all the machinery required to create a clathrin-coated pit and internalize the opioid. So when the opioid receptor is then internalized, it could no longer bind to opioid agonists, it can no longer function. And that is reversible, but it's going to take some time. Anytime you downregulate a receptor and digest it, which is what's happening, you're going to take, it's going to take quite a bit of time to get back to the normal state where you have a normal sensitivity to the opioid. So I have just the term or the word ouch up there because it's indicating that you can't treat the pain as well without escalating the dose of the opioid. And I would say by far, opioids are one of the most severe examples of a tolerance compared to other drugs. Some drugs have really no obvious tolerance that develops. Opioids are an extreme example of a very prominent tolerance effect. So this graph is representing what acquired tolerance would look like from one perspective, and that is what is the analgesic response over time? If you keep giving someone the same dose every day, what will happen is at first things are fine. You get the 100% of your maximum pain relief. It doesn't mean all your pain is gone. It means, but this is the maximum effect you can normally get, which may leave a little bit of pain, but then it's going to drop. And giving the same dose eventually becomes very, very low in effectiveness, and it gets close to placebo. Okay, so that's why people generally would have dose escalation over time. Another perspective for acquired tolerance is what if we look at the analgesic response in not the time, but the dose. So the morphine, for example, it could be anything, but we're talking about morphine in this case. The morphine dose, so let's first look at this. The morphine dose responds after prior treatment with placebo. So let's explain what this means. So this means if someone were just taking placebo, so no medication really, repeatedly taking that, it's not going to cause any tolerance. So what we're saying here is that as you escalate the dose of the morphine, in a fairly lower dose, you can start to get good pain relief. Right? As we make the dose higher and higher and higher, we get more and more pain relief. However, if we have prior exposure to morphine, we will see a shift in the curve to the right, and that always means that there's a lower sensitivity, or it basically takes more of the drug to produce the same effect. So we could also look at the EC50, or the effective concentration, producing half of the maximum analgesic response. That's going to go, it's going to be a higher dose if you look on the x-axis to produce the same response. So there's two ways of looking at it: is the time dependence, and then the dose of the medication that you were previously exposed to would have a bearing on how much tolerance you have. So if you had nothing, right, no dose, and just placebo, you would have no tolerance. So this brings us to physical dependence, and then that wraps up kind of the overview, and then not too many slides remaining on the drug specifics. That really I just want to point out the unique differences, or the important differences. So physical dependence is an adaptation which produces withdrawal symptoms when the drug is stopped. That means the longer either the longer you're on it or the higher the dose, that if you stop it, you're going to have some bothersome kind of withdrawal effects. So that would be things like diarrhea, because opioids cause constipation. If you stop them, you can have the opposite. You could have hyperbowel motility and poor water absorption and excess secretions. Mydriasis, not necessarily bothersome. Theoretically, you might have extra light sensitivity because your pupils will be dilated. Hypersensitivity to pain is a real problem, or hyperalgesia basically. And agitation is a very well-known effect from, for example, giving naloxone or Narcan for someone who's of an opioid overdose. It's very well known that they can become aggressive, violent, and agitated, and even someone who's on it chronically without overdosing, if they abruptly stop it, they could have an agitation. So finally, we're on section 2, which is the specific opioid medications. This is going to be fairly brief because I think many of the things about the opioids are very easy to generalize and common amongst the class, and there are just a few differences. So what are the important differences between drugs in the opioid class? So this slide and the next slide are just really a continuation of each other. So the second one is the second half of the table. And this table it's obviously pretty in-depth, and I don't plan on going over every part of it, but I'd like you guys to really use it more as a reference than trying to memorize everything. But what I have here is organized. They're basically organized by type. So are they natural, semi-synthetic, or synthetic? And you'll see more synthetics on the next slide. Typically, like how are they administered? And some of these might be missing a few dosage forms. And it's not something you have to commit to memory, but at least for my material. But morphine sulfate, for example, could be given orally, IV, or IM. A lot of the other ones are given orally or by other methods. Again, it's not necessarily all inclusive. Okay, so next I have the column on oral absorption. Okay, in hopefully this will shed some light on why, for example, morphine is not typically used orally, even though it can be. It's very variable or highly variable absorption due to metabolism before it gets into the bloodstream. But most of these opioids have very rapid oral absorption if they are given orally. One thing I wanted to point out, and it's in bold here, is oxycodone CR, which is also called OxyContin. That is controlled release. It should never be crushed or chewed, and that is what some people would abuse it that way, because if you crush it or chew it, you'll get the entire dose much more rapidly, and obviously could be very, very harmful or fatal, especially if you don't have a tolerance or anything like that. So normally it's about 12 hours it takes to get the full oral absorption. If you chew them, crush them, it might take 1 or 2 hours. So that's really, really important to understand, and for patients to understand. It should be just taken as the whole tablet, basically. Okay, and I'm not going to cover all of them in oral absorption. Just give you highlights. Distribution. Again, I'm not going to cover. Basically, if I don't cover it at all on here, it doesn't mean the distribution is not important. It just means there wasn't something really unique about it that I wanted to highlight. Okay, so obviously any one of these drugs, for them to work, they do have to distribute into the brain at some point, or the spinal cord, right? So just keep that in mind as a kind of a generalization. But I wanted to point out morphine. Morphine has very slow penetration through the blood-brain barrier, so it's not nearly as prominent as something like fentanyl, which has the most rapid blood-brain barrier penetration. And then, so the next column might not be obvious, but this is the drug active as the parent compound? That means when it is administered, is it already active, or does it need to be activated by metabolic enzymes? So if you have a dot here, that means it's already active. So morphine's active when you give it. Codeine is not. It needs to be metabolized. But most of them are active as given as a parent compound. But a lot of them do have metabolites that are also active. So if I have a dot here, that means it's definitely active when you give it, but it doesn't specify whether or not, at least the dot doesn't specify whether or not it's active when it's metabolized, but I have that in the next column. So you'll see over and over again, a lot of these are metabolized by the cytochrome P450 system. A lot of these are metabolized by the phase 2 enzymes, which would be, for example, glucuronidation is very, very common. So without getting into too much detail, just understand that if you had impaired glucuronidation, there are many, many medications here that will be impacted by that and maybe toxic because you can't break them down. If you had an alteration in CYP2D6 metabolism, probably the most important drug of this class to know is codeine, because you will not, right, if the CYP2D6 is low activity, you won't have enough effectiveness. You won't have pain relief. If CYP2D6 is hyperactive, it's all due to genetics, right? If that's hyperactive, then you'll have potentially toxicity and too much activity. And in fact, for codeine, there is a black box warning, and that means in the drug package insert or monograph, there's a warning right at the beginning of the label that's in a black box that says that there's a high risk for children undergoing adenoidectomy or tonsillectomy, high risk of toxicity due to differences in CYP2D6 activity. again, it's probably more prudent to actually use a different medication in that case for pediatrics. But then moving on, we see a couple more things like, so is it renally eliminated? Okay, the truth is almost all these are they're renally eliminated. That's how they get out of the body. But many of them are first metabolized in the liver. So the liver does the first thing, and then the kidneys are actually getting rid of the drug. So obviously, if you have renal impairment or renal failure, a lot of these drugs will have a higher blood concentration. So just keep that generalization in mind. And finally, without covering everything here, I'll just add that this one in particular, meperidine, which was brand name Demerol a long time ago, meperidine is not used nearly as often as it used to be, but that is toxic with CYP3A4 inhibitors. Most of these drugs are not heavily dependent on CYP3A4, but meperidine is. So that's one of the rare ones where if you had a drug that blocks that or another substrate and had competition, you might have toxicity. And meperidine is also toxic if combined with monoamine oxidase inhibitors. Toxic in the sense that because it already has norepinephrine reuptake ability, and if you add a monoamine oxidase inhibitor which prevents the metabolism of norepinephrine, you could have that excess sympathetic activity and that toxicity. So in fact, many of the opioids have shown evidence of SSRI or SNRI activity, so serotonin reuptake inhibition or norepinephrine reuptake inhibition. The one that has the most prominent, probably the most prominent of these effects would be tramadol. And in fact, because it's so prominent, people have experienced serotonin syndrome or toxicity when tramadol is combined with other drugs that affect that. So moving on to the rest of the table is fentanyl. Okay, fentanyl is a unique one because it is really one of the most potent opioids used in humans. It is not used orally because of very extensive first pass inactivation by CYP3A4. Right, so if you give it orally, it'll mostly be deactivated and it won't be useful. So that'd be low efficacy. It's one of the fastest drugs to distribute into the brain, fat and muscle. A very fast distribution rate. At first, that's the initial phase, and then there's a secondary phase. So it's got, again, a very, very rapid distribution. And then it has, just like the other ones, the same thing, renal elimination. And I have the half-lives on all of them, and those probably not something you're going to have to commit to memory at any point. But just understand when you look at dosing frequency later on, try to correlate that with the half-lives and say, oh, that makes sense because that's got a very short half-life. Maybe you do have to give this more, or this drug has a long half-life. Maybe you give it less frequently, for example. Again, fentanyl is about 100 times as potent as morphine, and you definitely can get fentanyl toxicity with CYP3A4 inhibitors. Okay, so that was so far meperidine and fentanyl are the unique ones that have a dependence on CYP3A4. So please keep those uniquenesses in mind. A special dosage form is duragesic. You could find ones that are generic now, but it's transdermal. Okay, I'm going to go over that on a few slides, exactly how that works. But it's going to be the same as regular fentanyl used IV or IM, etc. But because it is transdermal, it's a slow release from that patch. It's going to take, it's about 17 hours for its half-life. And I want to clarify, that doesn't mean that it's eliminated slower from blood. It means that it's gradually absorbed into the blood, so effectively it's going to have a longer half-life. Okay, so it's still being eliminated the same way. It's just that it's gradually being deposited into the blood. Fentanyl lozenge, Actique. I remember when I was working in a pharmacy, a community pharmacy, that we actually gave these out quite often. They were prescribed quite often, but I never actually got to see one at the time because they were in foil pouches. But these are kind of like lollipops, but not appealing to children because of the way they're designed. But they're very interesting. I'll talk about how they're used in one of the subsequent slides here. But fentanyl's given in the cheek or in the buccal membrane, okay, and then it's got a unique combination of absorption that way and then absorption through the GI tract, okay. And then I'll move on to a couple more highlights. Methadone is well known as one of the opioids that really the only one that I'm aware of that does this prominently, and that's QT prolongation, which means it's prolonging the QT interval on the EKG, so it can cause cardiac arrhythmias, and particularly torsades de pointe, which is a type of VFib, which is potentially fatal. So methadone, it's not that methadone is that dangerous, but it's that if someone overdosed or combined it with other drugs that do this, you could potentially then have an arrhythmia. So pharmacists should be aware of that QT prolongation effect. Tramadol is one of the oddballs because it has the most prominent SSRI and SNRI effects. It is active as a parent compound, but it has a very potent metabolite called M1. Okay, and that's produced by CYP2D6 again, and CYP2D6 is one of the most polymorphic enzymes, so people might produce too much or too little of this metabolite. So if you know, for example, if a patient already told you, and you probably want to confirm that with the paperwork or something, but yeah, if they said, well, I have really slow CYP2D6 activity, probably it's just best to go with a drug that doesn't require that rather than guessing. Right? Or if it's excessive, same thing. You might not want to go with a drug like this because you don't know exactly how it's going to impact that patient. Another really the newest one is tapentadol. Not going to mention anything there. Buprenorphine is one of the unique, really the only one I'm aware of that is a partial agonist. Okay, so that means it is going to activate opioid receptors, but if you give beyond a certain concentration or dose, it won't activate them any further. So you reach a plateau effect, which is nice because there's a lower risk of respiratory depression when buprenorphine is taken at too high of a concentration or too high of an amount. Okay, the warning is still in the package insert for respiratory depression, but there's definitely evidence that there's that ceiling effect or plateau effect that you don't have nearly as much of a risk as you do with the full agonist opioids. And buprenorphine has a very long half-life. I don't want everyone to be familiar with that. That it's not that it's 37 hours, but it's really one of the longest ones. Okay. It's typically given with naloxone, and I'm gonna talk about that on another slide exactly why. And then finally, we have naloxone and naltrexone. I put them in a different color here because they are antagonists, so they're strictly used to oppose the opioid agonists, either in an overdose or to deter abuse. Naloxone can be given in many different administration routes, commonly intranasally or IV, for example. And please make note that the half-life for naloxone is very low, very short. So repeated administration is often necessary if someone overdosed on an opioid that has a long half-life. And then naltrexone is not used as often. Naltrexone is an opioid antagonist, but it was traditionally used for, believe it or not, alcohol. Was it alcohol with not withdrawal, but I think to prevent alcohol abuse and things like that. But essentially, that's not as nearly as commonly used as naloxone for opioid overdose. So now that we're done with those large tables, I'm just going to wrap things up with just one diagram on the actual metabolism that I talked about, and then a few slides on the specific differences between some of the drugs or the uniquenesses. So remember, codeine is administered in a form that's not very potent. It needs to be converted into morphine by CYP2D6. So that, remember, that's our really variable enzyme there. And just for comparison, I have heroin on here. That's also, believe it or not, weak until it is metabolized by a different mechanism, that's deacetylation into morphine. Okay, so codeine and heroin are both broken down into morphine or metabolized into morphine. So they have that commonality there. But obviously the big difference is, we'll talk about this more in a little bit, but the amount of brain penetration of heroin or blood-brain barrier crossing is very, very prominent. Okay, and that's one of the main reasons why it's such a strong effect. Codeine, by the way, is used as a starting reagent to produce hydrocodone, which is what's in Vicodin and some other medications. So that would be considered why it's semi-synthetic, that hydrocodone. Okay, so that's just showing you that a scientist would be doing that. Someone in the lab would have to make that. Oxycodone is also synthetic. That is metabolized by CYP2D6, but that's quite a minor route. So it is active on its own, but it does get metabolized into oxymorphone, which actually is a medication. Okay, oxymorphone is a medication. It's not probably used as often as some of the other ones, but it does come from oxycodone metabolism also, like I said. And this is just highlighting the bottom here that there's a black box warning for codeine due to CYP2D6 polymorphisms. I already mentioned that. That's the children undergoing tonsillectomy or adenoidectomy. There's a very strong warning to avoid or be aware of the polymorphisms of CYP2D6 producing morphine too rapidly in some cases. So this slide is just highlighting how heroin and morphine are different, even though heroin is metabolized into morphine. And what it comes down to is the way heroin is administered. So first of all, heroin must be metabolized to be potent. Okay, so as you can see down here, no matter which way you take it, if you took it orally, which is not usually done, it would be metabolized into morphine. If you took it IV, it would eventually be metabolized into morphine. But that difference in location of metabolism is so critical. Okay, so it's actually deacetylated. As you can see here, deacetylated that's the metabolic activity that's happening when it's converted into morphine. That can happen in the liver or the brain. However, when it's taken orally, most of it is converted in the liver. And the problem with that is if someone wanted to get any activity, and of course we don't want that because it's an illicit drug, but if someone wanted to get that activity and they took it orally, if it was all converted into morphine in the liver, which it is for the most part, and morphine is a very poor blood-brain barrier penetration, they wouldn't really feel much high there. Okay, so they might get some in there, but they wouldn't get enough to have a really strong high. If you use it IV, you're bypassing the liver, you're going right into the systemic circulation. Of course, some of it will reach the liver because the liver gets some of the cardiac output, but a lot of it, the heroin will go right into the brain through the blood-brain barrier because it's very lipophilic. And then in the brain, it'll get converted into morphine, where so much of it will enter as heroin that you'll produce so much morphine that you'll get that strong euphoria. So what it comes down to is getting it into the brain before it is metabolized will allow you to really get much more in there to begin with. Okay, so if you look at the structure here, that deacetylation that happens is converting it from this to this, and just loss of that one group really reduces the lipophilicity and the blood-brain barrier penetration. So that's why you typically won't see people using heroin orally, right? They'd be using it IV, maybe inhalation or smoking, but IV is obviously the most common route there. So now we're moving on to the special dosage forms of fentanyl, which I already alluded to. So transdermal fentanyl is a small simple patch with a drug in adhesive matrix. So the drug is kind of suspended in the adhesive or dissolved in the adhesive matrix. The original brand name was Duragesic, and that's still around, but that looks like that package up top there. The actual patch is going to vary in size based on the dose, so it is actually labeled by the amount delivered per hour or mass per hour. So that is the rate of absorption. The maximum amount in there is still listed. As you can see, that one says 10 milligrams. This is kind of what it looks like when if you have the brand name, when you open up the pack, you see that patch there. So transdermal means the drug crosses through the dermis and into the capillaries. Actually, not through the dermis, but well, to some extent, but really has to get into the dermis to get into these blood vessels or capillaries. So it's not just epidermis, right? And maybe some gets in subcutaneous, but where a lot of the capillaries are going to be in this deep into the dermis here. So you need to get that to slowly diffuse through all those layers to get into the dermis. So it's released in a near constant rate. That's called zero order, and that's why it's listed as a mass per unit time rather than a percent per unit time. So you can expect delivery of the same mass every hour for quite a while, actually, until you've exhausted all of it in the patch. So the serum concentration peaks at about 30 hours, then slowly drops, with some still remaining in the serum for over 72 hours. However, if the patch is removed prematurely before it's exhausted, you will still have a large amount in the dermis and epidermis, and you'll still get absorption with approximately 50% reduction in the serum level in about 24 hours. So please understand, if someone takes the patch off right now, they're still going to have the opioid activity for quite a while. Okay, so at least 24 hours for, probably a little bit longer than that, because you'll still have about 50% by that point in time. So I'm just showing basically you take the adhesive layer off, you stick it on, and then the next slide is just showing you how it gets slowly kind of released from that patch. Released into the epidermis, and then some of them will travel to the dermis, and then some more over time, and so you'll get that linear absorption rate there, and then it'll get into the capillaries and the dermis. And then, of course, hopefully it'll travel where it needs to, which is through the blood-brain barrier and into the brain and the spinal cord to finally exert its effect. The other dosage form that's not used quite as often is the lozenge. It's not really a troche as much as it is a lozenge form, although it looks like a lollipop. It's a little different. It's actually quite different from a lollipop, because first of all, it's not designed to be appealing to children, of course, because that would be extremely dangerous. But also, this is a plastic tip, and the drug is dissolved or embedded in the plastic matrix, which is a little strange and a little different. So what happens is the patient would put this in their cheek, which is called the buccal membrane, and that'll slowly be dissolved and absorbed over time. And it's intended to be removed when you have pain relief, and it could be stored for use later on. The convenient thing, or the smart design about this, is it's not easily fractured. So it's, because if it were easily broken apart, potentially you could swallow pieces of the plastic and then get a lot down into the GI tract. Now, the very interesting point here is that you would think that if someone did swallow this plastic for some reason, if they chewed it, swallowed it, you think, well, maybe they get an overdose. But the reality is, because fentanyl undergoes so much first-pass metabolism, that you actually would typically get a lower efficacy and a lower amount in the blood than if you just left it in where it's supposed to be, which is in the cheek. So about 25% gets absorbed from the cheek, or buccal membrane, and that of course bypasses first pass metabolism and goes right to the blood. 75% does get into the GI tract, even if you're not trying to do that. So you're going to swallow it with saliva, but only about a third of that escapes metabolism, and about 2/3 is destroyed by metabolism. So effectively, you only get about 25% active in getting into the blood from the GI tract, and about 25% of the total dose from the buccal membrane. So about half of the dose gets destroyed before it gets utilized to have any efficacy there. And down here is just highlighting that point that I made about chewing it and swallowing it. Typically, for a lot of drugs, you expect, well, that might cause toxicity. In this case, it's much more likely that it's going to have poor efficacy. And now I'm just moving on to opioids with unique receptor activity. Specifically, tramadol is one of the main ones, and then buprenorphine. So I already mentioned a lot of this about tramadol. I just want to reiterate that it does have an active metabolite, and it's also active as a parent compound. The metabolite is even more active than the parent compound, and that is dependent on CYP2D6 for its production. So if this metabolic enzyme is hyperactive, you might have toxicity. If it's hypoactive, you might have poor efficacy. If there are drug interactions, then of course, so on and so forth, you could have changes in its effectiveness. The M1 metabolite, which is the active one that we're talking about, is O-desmethyltramadol. Okay, and I already mentioned these drug interactions. The other thing I wanted to add is that tramadol has the most profound SNRI and SSRI effects, meaning norepinephrine and serotonin reuptake inhibition. So there's a well-recognized risk of seizures when given with monoamine oxidase inhibitors, selective norepinephrine reuptake inhibitors, selective serotonin reuptake inhibitors, tricyclic antidepressants, and triptans that are used for migraines, such as sumatriptan and some of those other ones. Tramadol is advantageous in the sense that it does not produce histamine release, so there's very low risk of what looks like an allergic type reaction that will not be happening with tramadol, whereas it will with the other opioids. So finally, before I wrap up the lecture with a summary, I just wanted to talk about the specifics of buprenorphine. Buprenorphine is typically given with naloxone, but it doesn't have to be. And that combination product is brand name Suboxone. And this is kind of an interesting rationale and mechanism, because you might be tempted to think, as I was, that buprenorphine being a partial agonist, so it's not as strong as some of the other opioids, being combined with naloxone, it would seem to make no sense and be futile, because the naloxone you would think would inhibit the activity of the buprenorphine, and then what is the purpose of giving it, period? And I'm going to kind of demystify that, I hope, here by explaining that rationale. So buprenorphine, like I said, it's a partial agonist of the mu opioid receptor. The other medications are really not. They're pretty much full agonists. And that means that there's a ceiling effect. So there is evidence that there's a lower likelihood of severe side effects from overdose, such as severe respiratory depression. Now, the package insert does list it as a side effect, or there's a warning for respiratory depression, because just to be conservative and prudent, but also if you combine buprenorphine with other respiratory depressants that work either by the same or a different mechanism, meaning other things that affect the mu opioid receptors or activate them, or completely different mechanisms like benzodiazepines, there's still a risk of respiratory depression. Okay, so when administered correctly, which is sublingually, the way it works is that the naloxone does not really get strongly absorbed or effectively absorbed, but the buprenorphine does. And that means that you'll still get the analgesia. So you might be asking, why is naloxone in there, period, then? What was the purpose of it? The purpose is that if someone injects this, dissolves it and injects it IV or any other injectable route, the naloxone will get into the blood and it will inhibit buprenorphine. And what that does is, first of all, it deters abuse, and it also would deter use in that form with, for example, other opioids and things like that, other illicit opioids, I should say. But the main point is that it deters that overdose, overdosing it intentionally through IV use, because you'll block its effectiveness and you'll block the euphoria. Whereas if you take it the correct way, which is sublingual, you will not block the analgesia, and you won't get much euphoria really, because it's a very it's a very controlled amount and it's a partial agonist. So in addition to that, if someone happened to be abusing heroin or another opioid, and they did inject Suboxone after somehow dissolving it or suspending it, they could definitely get opioid withdrawal, which is pretty much never fatal, but there is a risk of things like severe diarrhea, agitation or aggressiveness, and things like that. And just some of the main side effects will be kind of opposed to the opposite extreme, you'll see. So that pretty much wraps up the specific discussion on the individual drugs, and then I'm just going to finish with a summary of everything, and that's about it, and then wrap up the lecture. So if you made it this far, I'd like to thank you for being able to keep your attention. And what I'm going to do here is just summarize the big important points that we talked about. First of all, fast and slow pain neurons exist. Opioids were originally natural, and we still use natural opioids, but now several semi-synthetic and synthetic congeners exist. Endogenous opioids and opioid analgesics primarily are activating the mu opioid receptors. That's the major important target. Opioids do exhibit variable blood-brain barrier penetration and highly variable elimination rates. The special dosage forms warrant careful attention to the unique absorption pharmacokinetics. Opioid antagonists can be used either to treat opioid overdose or to deter abuse in combination products such as buprenorphine with naloxone. Tolerance exists to most opioid effects due to receptor downregulation or desensitization, but constipation, pruritus, meiosis can persist. But I would say constipation is the most common one. Well, it's the guaranteed one to not really go away, whereas the other ones can potentially dissipate over time in some cases. CYP2D6 activity influences the response to codeine, and please add tramadol. Several opioids act as SSRI or SNRIs, and that means what I would say is the default approach to this is if someone is taking a monoamine oxidase inhibitor or an SSRI or a tricyclic antidepressant or even a triptan type of drug, it's always best to check what the recommendation is for the specific opioid that's being considered. And tramadol is the most prominent one that can cause seizures in these combination situations. Buprenorphine is unique in that it's a partial agonist, and that means there's a lower risk of too much activity and too much respiratory depression, and the other side effects as well. Buprenorphine combined with naloxone is strategically designed to deter abuse by injection. So please understand that specific that dosage form, that sublingual dosage form, the reason why that's important to not take it a different way when you're trying to get efficacy, but not right. You're not trying to oppose the opioid unless someone takes it the wrong way and tries to abuse it. So it's a very intelligent design there. And I think that wraps everything up. And again, if you made it this far, I appreciate it. And if you have any questions or comments, please let me know. And I hope everyone has a great day, and thank you again.